Welcome to Hospital at Home Policy Ahead, the Waiver, its extension, and beyond, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine. We would also like to recognize the generous support of the John A. Hartford Foundation for the Users Group and this webinar series. The Users Group is the nation's premier collaborative focused on acute care at home. The Users Group shares resources and best practices, works together to expand our program's reach, and informs regulatory, reimbursement, and payment policies necessary to build the field and spread this hopeful, person-centered model of care. Please visit our website. Be sure to check out our Technical Assistance Center for helpful HOP program resources and tools, as well as our regularly refreshed Research Center. And follow us on LinkedIn, which is new. You can view any of our now 34 Users Group webinars on our website. So find a topic you've been thinking about or working on and take a look. And registration is open for our annual meeting, Leveling Up, Investing in HA and the Future of Healthcare. It is scheduled for October 16th. We have exciting programming, including special sessions on caregiving and expanding HA for our rural populations, a policy update, an engaging keynote from Dr. Jeremy Bull, networking opportunities, research presentations, awards showcasing the best of the HA community, and more. So please visit our website to learn more and register. It's going to be a great time. And as in years past, the Users Group meeting will be a pre-conference for the in-person American Academy of Home Care Medicine annual meeting in October on October 17th and 18th. So we hope to see you virtually and or in person. So this is a call to all active hospital at home programs. Please help us advance the field of HA by participating in our minimum data set initiative. This has been developed by the Users Group Quality Indicators Council. It is a de-identified patient-level data set that seeks to capture information on all patients enrolled in HA programs nationwide. By participating in this initiative, hospitals will receive annual benchmarking reports to help assess program performance, identify areas for growth and improvement, demonstrate program value to internal and external stakeholders, and move the policy and regulatory conversation forward with a national data set. There is no cost to participate. We hope you will join the 46 hospitals that are already involved in this essential work. Please scan the QR code and fill out a short interest survey, and our team will be in touch with you. So it is now my pleasure to introduce our moderator for today's webinar, Lisa Tripp. Lisa Tripp, JD, is a nationally recognized expert on healthcare regulatory matters. She has more than 2 decades of experience working with health facility regulators at the state and federal levels. In 2020, she was appointed to the CMS CDC COVID-19 task force, where she helped draft the Hospital Without Walls waivers, and then co-led the team that wrote and implemented the CMS Acute Hospital Care at Home waiver. After leaving government in 2021, Lisa led the advocacy team at Medically Home, which was instrumental in getting Congress to extend the CMS Acute Hospital Care at Home waiver in 2022, and getting the House and Senate to introduce bills for a 5-year extension of the waiver in 2024. Lisa also worked with Medically Home customers in more than a dozen states to navigate a wide range of regulatory issues. She has been a frequent speaker at health regulatory conferences, and in April of 2024, she co-chaired the first conference to focus specifically on the legal and regulatory aspects of hospital at home. Please take it away, Lisa.
Thank you so much, Gabby. I really appreciate the introduction. I'm so excited today to be talking about hospital at home with a very large audience. We understand that more than 300 people signed up for today's webinar. And while some of us might like to think perhaps we were part of that attraction, I can assure you we were not. The reason we have such an amazing audience today is because of my dear friends and colleagues, Danielle Adams and Ashby Wolf, who have truly been the single most important champions at CMS for hospital at home since its inception. So we're so happy to have both of you here today. And I also want to thank the Users Group. The Hospital at Home Users Group has time and again been the most important voice to bring the whole hospital at home community together at a really important time, and now is one of those times. So Danielle and Ashby, I'll let you guys introduce yourselves, because I think you guys can do a better job than if I just read it off. So we'll start with you, Danielle, then we'll go with you, Ashby.
Thank you. My name is Danielle Adams. I am a nurse at CMS. In addition to my other work on hospital and critical access hospital health policy and conditions of participation, I am the co-lead for the Hospital at Home waiver initiative. Ashby?
Thanks, Danielle, and a pleasure to be with you all today. I'm Ashby Wolf. I am the other co-lead for the Acute Hospital Care at Home initiative at CMS. I'm a family physician and have been in practice for about 15 years. I've been at CMS for 10 in the position of Regional Chief Medical Officer. And just a pleasure to be here and excited to have our conversation. Thanks, Lisa.
All right, thank you so much, Ashby. Well, we see that you guys don't have any disclosures to share, so that's great. So we'll kind of move on now with the discussion portion of the webinar today. We've prepared a couple of questions with your assistance. And I want to just start, with the very most important parts. Can you give us an update on where we stand with the hospital at home waiver? I'll start with you, Danielle. What does it look like in terms of number of hospitals, number of patients, number of states? I keep hoping we get over this new mark with states, but you'll let us know. So take it away.
Yes, so as of today, we still have 39 states. We have not crossed the threshold of 40 yet, but there are 413 hospitals that have approved waivers, and we have served 48,500 patients since November of 2020.
Wow. Do you mean when you give that number, Danielle, does that include MA and commercial patients, or is that?
No, that is just fee-for-service, Medicare, Medicaid, non-managed care, Medicaid, and duals.
Okay, so the actual number would be probably considerably higher than that if we were to add in those other populations.
Care Advantage and commercial pay. Yes.
That's terrific. Well, that's when we were all thinking about hospital at home at the beginning, if somebody had said to any of us that you would be saying today 44,000 patients, we would never have believed it was possible. So that's an astonishing thing. And I just want to remind everybody, every single hospital that has been approved for the waiver has been personally interviewed by Danielle and Ashby and some others, except for that tiny cadre of hospitals like Mount Sinai, for example, that got fast-tracked. So you all have touched all of those hospitals and approved all of those hospitals for waivers. So that's terrific. I'm going to switch over to you now, Ashby, and ask you the really hard. I gave Danielle, but give us the facts, and now I'm going to give you a slightly different question. Everybody on today's webinar, it has September 30th marked on their calendar because that is the day that the legislation authorizing the continuation of hospital at home is going to expire unless it is renewed. And I know that a lot of people in the audience may think that you all perhaps have some control over what happens with the legislation. So I thought it might be helpful for you to give the audience a sense of how things work between Congress and CMS.
Yeah, that is the question of the day. And thank you. I also just want to thank the Hospital Home Users Group for having us here and for the ongoing support and collaboration from the practice community. I know, as Lisa mentioned, we've spoken with every program at least once during the course of this initiative. And often, as we've seen with the sort of repeat congressional extensions of this initiative, the constant question is what's going to happen after X date. So the X date this time around is September 30th of this year, which is when the initiative is set to end, pending congressional action. So I'm just going to kind of speak to that a little bit to kind of decompress it for everyone. So just again, to remind everyone, the premise of the waivers and the Acute Hospital Care at Home initiative itself was originally designed to decompress acute care hospitals and expand capacity during COVID-19 surges under the declared public health emergency. And the waiver itself is tied to hospital payment requirements under CMS, what we call 1135 waiver authority. And that authority we can use to address emergent situations when there is a declared national public health emergency. So that is really important in allowing us to do this waiver. The emergency authority is what allows us to waive these conditions of participation and allows for payment at the DRG level for hospital care to be provided in the home. Our waivers are also tied to inpatient prospective payment system payment flexibilities for the telehealth component of acute hospital care at home, among other things, which then allows hospitals to deliver that care in the home on a 24/7 basis. And so all of this is really important foundational context because the COVID-19 public health emergency was declared ended in May of 2023. And without Congress telling CMS, continue please doing the acute hospital care at home initiative, this would have ended in May of 2023 as well. So really it was Congress's action directing CMS that we had the ability to continue our emergency authority around these waivers to continue to do this work. And of course, we've seen Congress extend our authority to do this work through December of 2024. Then we saw them extend it a little bit into March of 2025. And now, of course, we're at another extension termination point, potentially of September 30th. And we are very much aware that this sort of piecemeal approach to extensions and the short extension time is very challenging, not only for program operations in general, but for long-term planning. And obviously that ability to plan more into long-term is preferable for a number of reasons, sustainability being one, program development and operations planning being another. And Danielle and I have communicated those concerns that we've heard from the practice community to Congress. We are also aware that there are some concerns out there about hospitals that are excluded from the inpatient prospective payment system and so have not been able to participate in the acute hospital care at home initiative as it currently stands. And as I mentioned, this waiver was set up to decompress acute care hospitals during COVID, and it was set up all around the DRG payment structure. And of course, we never anticipated that this would persist for 5 years as it has. So we continue to examine these issues to understand what our current authorities are, whether there a future statutory or regulatory solution or both is needed. And we continue to engage with our colleagues within the CMS Office of Legislation and, of course, our colleagues on the Hill in Congress that are considering what to do after September 30th. And so what are we going to do? The answer is right now, we don't know. CMS authority is tied to whether or not Congress tells CMS to do something different than we have been doing, whether there is just a blanket extension or something else. In the event that there is an extension, this work, of course, will continue. And depending on what Congress directs CMS to do, Danielle and I have actually been brainstorming ways to further information share, develop best practice discussions, and further engage you all as the hospital at home community in ongoing dialogue. As this care environment is evolving on a daily basis, we're learning lots of different best practices and lessons learned. And we're particularly interested in understanding how we can further support our rural communities and patients who may not be able to take advantage of these opportunities right now because of geographical concerns. So we continue to monitor the evolution of care in the field. And of course, there's been lots of development, particularly around the publication of hospital at home practice standards and other things that have continued to evolve the discussion. So more to come, obviously, as we look towards the end of September. But we are here to hear your concerns if you have them, and really looking forward to opportunities in the future. Back to you, Lisa.
Oh, that's a great explanation, Ashby. I think you really captured well that the ultimate authority structure lies with Congress, but that there is a relationship where there is communication between your team and the Office of Legislation and CMS and members of Congress to inform them about critical things that they need to know. So I think that's an excellent answer. I think a lot of folks think that CMS is the architect of all of these things. And in many ways, CMS is sort of the builder and Congress is really the architect. So thank you for pointing that out so eloquently. I'm going to switch gears now, and I'm going to go ahead and I'm going to give you 2 bits of information. That's just my personal opinion. This is not the opinion of the Hospital Home Users Group or anybody else. It's just my opinion. It's my opinion that because the waiver legislation is budget neutral, it does not cost the taxpayers any additional money to do hospital at home because the payment is one-to-one, and that was a finding by the Congressional Budget Office. I believe because of that and because of the bipartisan support, it is very, very likely that Congress will continue to extend. It just isn't clear how long the extensions will be. So that's my personal opinion. Danielle, I'm going to ask you now the counterfactual.
Mhm.
All right, what if there is a shutdown? Or what if there is, God forbid, a lapse in congressional authorization of the waiver? Could existing hospital at home programs still offer hospital at home to non-Medicare fee-for-service, non-Medicare fee-for-service populations, meaning essentially managed care or commercially insured patients?
So there's two components to that, and one being the shutdown. If a government shuts down, that really just means that Ashby and I do not get paid. The rest of the government, hospitals, whoever receives funding from the government would continue to operate. All of our programs continue to operate. It's just that there's not a budget for to fund the federal government, and not because Medicare funds are appropriated funds. That's something separate. So they would always get paid. The providers would get paid. It's just actual funding the operations of the government. So if you have a waiver and the government were to shut down, you would continue operating as you do. Now, if there is a lapse in the waiver, then as long as the patients are not Medicare fee-for-service or non-managed care Medicaid, then they can still, the hospitals can still participate as long as it is allowed by their state law. Because that is the other component. It's great that Medicare can give the waiver, but if the state doesn't allow that under their state licensure, then the hospital isn't permitted, which is, we have had that in some states where some states do not permit acute hospital care at home to happen. Other states have had to work with their state legislature to change some rules from a licensing standpoint to allow hospital at home. So just being clear, a government shutdown versus a lapse in the waiver have two different effects.
Super helpful. Thank you so much, Danielle. I'm going to switch gears right now and ask a question that's not so much tied to the pending legislation, but it's one that health systems really care about a great deal. And that's, of course, the Joint Commission and possible surveys. So could you give us the latest information on whether or not the Joint Commission will be surveying hospital at home specifically?
So fortunately, in part of my other role is we do have oversight over the accreditation organizations, which is really important. So we have this conversation very frequently about what does hospital at home mean to an accredited or deemed hospital. So because hospital at home is just like another unit of the hospital, there is nothing specific that they would be surveying for. They may pull up hospital at home patients in their record sample for their closed records. They may pull them up in an open record sample when they're looking at medical records. In that, when that happens, yes, they may conduct an interview, they may review the electronic health record. But beyond that, that's really all the expectation. Now, where there could potentially be a concern is if there is a complaint that is received either by the Joint Commission or by the state survey agency related to care provided to a patient in their home, then at that point, it would open up a complaint investigation. In either way, they would still survey the same way. They would look at medical records. They would interview staff. They would interview leadership. They may do observations of care. The likelihood of them going into the patient's home, I would say probably less likely because we don't have an authority to go into the home, but that would not stop them from doing interviews or doing observations of virtual care. So that is where you could see a direct impact on acute hospital care at home, is if you do have a complaint or an allegation of noncompliance with the conditions of participation for those patients receiving care in their home.
Gotcha. That's super helpful. Right now, just to also to kind of orient the audience, typically when the Joint Commission is surveying a hospital, they're doing so under typically it's under a deeming authority, which means if you pass the Joint Commission survey, you're deemed to be in compliance with federal regulations governing Medicare participating hospitals. There are no regulations right now that are specific to hospital at home. And that's another follow-up I have for you, Danielle. Do you anticipate the drafting of hospital at home specific regulations now in the future, or can you give us some insight into that?
So, because currently, if I'm just saying in current state, based on how hospital at home is set up as another unit of the hospital, there would not be a need to develop new conditions of participation if this became permanent. The only way we would consider doing conditions of participation specific to hospital care at home would be if there was this statutorily was made into a separate provider type.
Mm-hmm.
And it would also require a long-term permanent provider type or payment model for CMS before we would consider doing developing conditions for coverage or conditions of participation specific to hospital at home.
That's terrific. I'm going to give last question from me, and then we'll open it up to the Q&A. I'm going to give it to Ashby. Ashby, I would love, you're an amazing physician, by the way, and I know you have a background with an interest in sickle cell, and I've been talking to some health systems that are moving forward right now with planning specific hospital at home programs specific to that diagnosis. What I would love to know from you is, what have you learned over this very unexpected, almost 5-year journey, and what surprised you, and what do you think is left to come?
That's a great question. And I think we have learned a tremendous amount from our opportunities, both internally and our collaboration with programs that are actively participating in the Acute Hospital Care at Home initiative. I think first and foremost, we have learned fundamentally there is nothing more important than guardrails for patient safety. That was how the waiver was initially designed. It's been informed by extensive collaboration with those who do this work in the field, but also an understanding that we have to be vigilant that hospitals are really ready to respond to those acute care changes in a patient's clinical condition, and ensuring that those seamless modes of communication and those protocols that exist on paper actually are actionable by every member of the care team. So we've seen some really excellent best practices developing around these kinds of patient safety parameters. For example, before the patient's transported home, a timeout with the whole care team and with the transport staff, modeled after the surgical timeout, a way to ensure that every member of the team believes this patient is appropriate, that we're ready for transport, that all of the checklist has been evaluated and reviewed, and that we're ready to go. That's an excellent best practice that is modeled after ensuring this patient is appropriate and that it's safe to move. We've also seen some really interesting protocols developed around collaborating with emergency medicine responders in the field. Should a patient or family member call 911 instead of engaging with the hospital at home care team? Obviously, we want acute changes in clinical condition to be appropriately responded to. And so leveraging our EMS community partners is really critical, but it's also critical to ensure that those folks who are responding know that these patients are hospital at home and can engage when clinically appropriate with the care team to ensure that all of that work that's been done in the home actually goes with the patient, either to the home facility or, if clinically appropriate, to a location that's more appropriate for that acute change in condition. And so all of that is sort of underlaid by the importance of ensuring the teams that are providing care in the home communicate well, that there are established protocols, and that there's opportunities to ensure the same standard of care that we provide patients in the brick and mortar facility is conferred to those who are in the home. Again, as we've articulated, it's really another unit of the hospital inpatient services that are provided. And so we really encourage hospitals to think about their hospital at home service as yet another inpatient service that's provided with the same expectations for those patients as we would have for any other inpatient. And we've really been overwhelmed by the incredible learning and opportunities for continuous quality improvement that we've seen in the field.
Yeah, terrific. Thank you so much, Ashby. I really appreciate that. I'm going to go to the chat right now. So Ashley Swartz asks, as I understand, the waiver covers fee-for-service Medicare and Medicaid patients. However, each state has to approve coverage of Medicaid patients. Do you have any thoughts of how to get states to come on board with coverage for Medicaid patients? To my knowledge, Pennsylvania is not on board with the Medicaid portion of the waiver. Any thoughts about Medicaid?
Yeah, so we have talked to our partners at CMS in the Medicaid space, and it really, there's nothing from the federal side of Medicaid that affects Medicaid participation. And really, it's a lot of engaging with your state Medicaid agency, working with your state government. That's really where the conversations happen. There are some states, we've heard from some states where they want to do it, but they're just not sure. They don't know, what does this actually mean? We've heard from some states that just the short-term extensions really to commit those resources, they're just a little concerned about committing those resources if there's not going to be a longer term extension. So it really is one, communicating with your state Medicaid agency to figure out what is the concern. If you find that there's a concern that maybe they don't have enough information, you can always reach out to us. We can always provide you, with any information that you may need to share with your state Medicaid agency. I think it's really just understanding what are their concerns and why, what are their barriers to being able to provide Medicaid services and Medicaid coverage for hospital at home patients in your state.
Yeah, that's great advice, Danielle. I would also add, I think it would be very helpful. Late in 2020, CMS notified all the state Medicaid directors that they didn't have to have a state plan amendment. They didn't have to do anything at all to approve Medicaid for hospital at home, as long as they paid it the same way. So I think if I could put a plug in while we've got you guys here, if it would be possible for CM, Center for Medicaid, to remind our colleagues out in the field, that could be helpful as well, because there's been a lot of turnover, and I think a lot of folks have forgotten that initial communication.
Yeah, and we do have regular engagement with our partners in CMCS, which is the Medicaid side. We like to continue to touch base with components within CMS that are not directly involved with acute hospital care at home, but have a piece within it, whether it's our partners in CM, our partners in program integrity, which is the fraud and abuse side, also our partners in Medicaid, just so we can kind of keep everybody abreast of what's happening with hospital at home and remind folks of of what we're doing, what the impact is to their component, as long as we have the waiver initiative.
Gotcha. That's super helpful. I want to go back to the chat. Mandy McGowan asked regarding state authority to allow hospital at home services for non-Medicare fee-for-service patients in the absence of the waiver. Does that only apply if the state legislative language does not tie hospital services to the CMS waiver? I'll give you my take on that, Mandy, and then Danielle and Ashby, you tell me if you think this is right. I think those two are in. So I think the correct way to think through this is you have to go and consult your state law, as Danielle said earlier, about whether or not you can continue to do this. And you would have to examine whatever legal authority exists in the state. And if that legal authority says the CMS waiver must be in effect, then that would be indicative that that state law may not allow. But it's very difficult to sort of give any sort of authoritative opinion about that in the absence of actually being able to see the text of the authorizing legislation. So Danielle, did I get most of that right? Okay. All right.
Hey,
Let's see.
Lisa, I've noticed there's a couple of points in the chat around clarifying issues of budget shutdown versus end of the waiver. So if I could just speak to that real quick. I saw that Kathy had a question and then Amy had a clarifying question and a couple others. So again, just to be clear, budget shutdown may or may not mean ending of the Acute Hospital Care at Home initiative. They are two different things, as Danielle articulated. And really, when we're talking hospital at home, if Congress does in fact, if the budget shutdown occurs and Congress has not acted on this September 30th date, then we do not have an extension of the Acute Hospital Care at Home initiative. And so that is where we're going with what Danielle mentioned, which is the budget issue is separate. We're talking about whether or not Congress is going to give CMS continued authority for hospital at home beyond September 30th. And if Congress does not act, so in other words, September 30th becomes the end, or there is a lapse in our authority to do hospital at home through the AHCaH initiative, all Medicare fee-for-service and non-managed Medicaid patients who are being cared for in the home under an approved waiver must have some form of disposition before October 1st. That means that if they are expected to continue to need inpatient care, there must be a plan to transport those patients back to the appropriate inpatient unit of the hospital within the brick and mortar facility. If the patient was planning towards discharge on September 30th, then those plans can continue as long as the patient is discharged from inpatient care and they clinically do not need inpatient care on October 1st. So if any of you all have additional questions about that or need further clarification around a specific clinical scenario, please don't hesitate to reach out to us. We would really greatly appreciate the opportunity to speak with you about that.
Thank you so much, Ashby. I really appreciate that. I just saw a new question. Can Congress act sometime after September 30th to extend or reinstate the waiver? Danielle?
Yeah, they can do that at any time. Congress has the authority that they can, enact the waiver at any time. We would hope that it would be before September 30th so that there is not a lapse in the waiver. And I will be completely transparent. We have not discussed, which we will probably need to discuss, how we are going to communicate. What does that mean if there is a lapse in the waiver? If you already had the waiver, does that continue? Or, what we would be allowed to do. So that would be information that will be forthcoming to all of our participating hospitals. We're still trying to work through that. So in the spirit of transparency, I just wanted to share that with you.
I appreciate that, Danielle. So it looks like we are wrapping up this segment of the discussion, and we'll have Meredith Yinger of Healthsperian is going to be on next. I do want to thank Danielle and Ashby, and also send a shout out to Doug Clark, our dear friend, Doug Olson, and Lee Fleischer and others who were so instrumental in creating the CMS Acute Hospital Care at Home waiver. Thank you both again for your continued extraordinary leadership in this space. It's been amazing. And then last thing I'll say, Bruce let us know that guess what's on the cover of Newsweek magazine right now? It's Acute Hospital Care at Home. It's hospital at home. And so that's such a credit to the great work that you and Danielle and Ashby have done, and many others, to make this a safe, high quality, great model of care. So I'll turn it over to you, Annabelle.
Good afternoon, everyone. It's great to be with you, and thank you for having me. I'm Meredith Yinger. I'm a Senior Policy Director at Healthsperian. Healthsperian is a DC-based health policy and strategy consulting firm, and I have the pleasure of working regularly with the Hospital at Home Users Group Board. And my job today is to give you a broad federal update with respect to both what's happening in the administration as well as on Capitol Hill, and how those dynamics might impact opportunities to educate federal policymakers on the hospital at home program, the wonderful care you all provide, and perhaps more permanent or longer term waiver opportunities in the future. So thank you for having me. Just to give you a sense of what we're going to talk about, I'm going to start with a federal update, talk about some of President Trump's key priorities for healthcare, as well as what's happening in Congress and what's happened so far in this 119th Congress. We're going to talk about how those dynamics create opportunities for you all, and then we're going to talk specifically about where government funding conversations currently are and how those may impact an extension of the waiver, as well as opportunities for how you all can engage and educate with your congressional offices right now about the importance of the hospital at home waiver. So let's jump right in. Next slide on the federal update. So the Trump administration in the past couple of months has really dove deeply into its healthcare priorities. Many of you may have heard of the Make America Healthy Again agenda or initiative that the administration is really focused on and even ran their campaign on, right? And so that initiative focuses on a number of key priorities that you can see listed here. There's a significant focus on chronic disease prevention and management. The administration released its Make America Healthy Again strategy earlier this week, and it has a very strong emphasis on improving child health in order to ultimately improve adult health and prevent the onset of chronic disease. In the adult population, there's a significant focus on improving tertiary prevention and management of chronic diseases and really tackling the root causes of chronic disease instead of treating the symptoms is often how you'll hear administration officials talk about this priority. There's also a really strong interest in drug pricing and making pharmaceuticals more affordable for patients across the nation. I think we have a lot of healthcare providers on the line with us today, and you all know firsthand how important affordability is. And so this is a significant focus of the administration, and I believe will continue to be. There's also significant interest in advancing a competitive healthcare marketplace and price transparency, including in hospital services. And finally, I would highlight these last two opportunities. The administration is really interested in this idea of technology enablement and really putting technological tools in the hands of patients to empower them to improve their healthcare. And we've seen a lot of movement in this space, and I think it's very well aligned with the hospital at home movement and the innovation that you all have really been on the forefront of. And finally, the administration is really interested in addressing fraud, waste, and abuse across federal health programs. And this is something that they've made a priority in order to ensure that federal dollars are being spent effectively. So as I mentioned, there's a lot of opportunity for the hospital at home movement to align with the president's agenda. That includes issues related to technology and innovation, which are, of course, integral to the ability to deliver hospital services at home. The administration I mentioned is really interested in this idea of empowering patients to optimize their own health and improving competition and patient choice, and providing folks the opportunity and the option to receive their acute care at home is really aligned with those ideas. And of course, I don't even need probably to explain how hospital at home is an excellent use of effectively using healthcare resources and can help reduce federal spending overall, which is a significant goal of the administration's. So let's talk a little bit about what Congress has been up to lately. So since this Congress began, we've seen a number of interesting things occur. So first, and this will sound familiar, Congress passed a continuing resolution to continue funding the government at pre-existing levels in March of 2025. And that the passage of that legislation created an interesting dynamic because there were bipartisan healthcare priorities that had been negotiated, and those were put aside in order to enact this continuing resolution. So that really set the stage for some of the political dynamics in Congress at the beginning of this Congress. Folks have probably also heard of the One Big Beautiful Bill Act, which was passed in July and signed by the president on July 4th. This is a really significant piece of healthcare legislation. It enacts very significant funding reductions that are going to lead to about 10 million estimated individuals losing their health insurance coverage under both Medicaid and the Affordable Care Act. Beyond the federal funding cuts, which I think folks are probably really experiencing with respect to their state Medicaid programs, it also enacted a number of smaller healthcare reforms to advance, for example, access to direct primary care and high deductible health plan beneficiaries and telehealth. I think the dynamic that the One Big Beautiful Bill Act created in Congress is very much impacting where we are today. This bill was passed using something called budget reconciliation, which essentially bypasses typical congressional rules so that legislation can be passed with a simple majority instead of requiring 60 votes in the Senate. So Republicans, which currently control both the House and the Senate, chose to enact their legislation that way because they don't have 60 Republicans in the Senate. And essentially, this process bypasses participation in many ways by Democrats who are currently in the minority. And so that has created some significant political tension on the Hill that is impacting the government funding discussions that we're talking about today. Of course, in July, there was also the bicameral reintroduction of legislation that would extend the hospital at home waiver program for 5 years. And this is just a vital step towards advancing a 5-year waiver extension. Having legislation introduced allows for other members of Congress to provide their support, which can help move the legislation through the legislative process. You'll see here with my very big yellow star that right now Congress is having discussions about how to fund the government for another fiscal year. And you heard Ashby and Danielle talk about some of the dynamics here and how they impact the waiver. We're going to get into that again. But like they mentioned, the hospital at home waiver expires on September 30th, which is the same day the government funding expires. And so the expectation is that a waiver extension would likely be passed along with some mechanism for government funding. And we'll talk about what those options are. And finally, I wanted to highlight that there's been some interesting discussion about a possible bipartisan end-of-year healthcare package, which would be passed sometime after the government is funded. Likely in the fall or early winter. And this could be a really key opportunity to educate lawmakers on the benefits of a longer term extension of the acute hospital at home waiver. So let's dive in a little bit more specifically on this dynamic of government funding and the waiver. Next slide, please. Okay, so as I mentioned, the waiver is set to expire on September 30th. We expect that an extension would move through Congress with a federal funding bill. However, a waiver extension could be passed separately of a federal funding bill. Congress has a lot of opportunities and options that it could leverage to to extend the waiver as well as to fund the government. And right now, what looks most likely is a continuing resolution, which would provide, again, short-term stopgap funding at current government funding levels. And so that would be different than if Congress chose to advance bills through the formal appropriations process to set new funding levels for the fiscal year. So again, we expect a short-term funding bill to advance, and most likely that means that we would see a somewhat short-term waiver extension advance as well. We would typically expect Congress to advance a waiver extension that matches the time period of the continuing resolution. So for example, if Congress decides that they are going to pass a continuing resolution through December 31st, we would expect a similar length waiver extension. That said, they are able to extend the waiver for longer if they want to. So we could see them pass a short-term funding bill and a longer-term, perhaps a year-long waiver extension. As you all know, and it's worth repeating, the hospital at home waiver and the really kind of accompanying telehealth Medicare waiver both enjoy very strong bipartisan and public support. And so we do expect them to be extended, and we hope that they will be extended without disruptions in care. All of that said, as Danielle and Ashby alluded to, a government shutdown is absolutely still possible. And I think there's a lot of discussions going on the Hill right now to avert that shutdown. Those discussions are going to continue. Right now, folks are negotiating over a couple of issues, including how long a potential continuing resolution would last for. The White House has indicated that they would prefer a continuing resolution that would last until or through January 31st. But Congress has really been focusing on shorter term continuing resolutions. For example, there was discussion of a 45-day CR. All of that said, I think these negotiations are really going to continue, and we won't know the outcome until we know. And I know that that's really frustrating, but I do want to be honest that these conversations are changing every day. Okay, so just to talk about some of the movement we're seeing right now, and the goal here is really to share with you that there is momentum to enact government funding and a waiver extension. We are seeing Republicans move their appropriations bills through the typical process. Right now, the House is really focused on passing its appropriations bills, and they've been moving them. For example, the HHS funding bill recently moved from the Health Subcommittee to the Full Appropriations Committee, and now it will move to the House floor. The challenge is that bill is going to face challenges achieving those 60 necessary votes in the Senate that we talked about, and this makes that short-term funding extension more likely. On the continuing resolution or short-term extension side, I've noted here that there are sort of different time periods that are being discussed, and as I mentioned, these negotiations will continue. As Danielle and Ashby noted earlier, we've discussed that the waiver could lapse come October 1st if Congress doesn't extend it and there's a government shutdown. We just want to sort of stress that participants should have a plan in place to pause operations, make sure patients have a required disposition. And we would absolutely, in this case, look to CMS for guidance for all of you. They would be the best source of truth. Okay, and now let's briefly talk about opportunities for congressional education. So the Hospital at Home Users Group recently created this evidence summary with the goal that you all and some of our stakeholder friends across healthcare could use this in your meetings with lawmakers to educate them on all of the evidence that supports the positive outcomes of the Hospital at Home program. Given that the waiver expiration is really up for grabs right now, and there's active conversations going on about government funding. Now is a great time to reach out to your lawmakers to provide this education. You can find this new one-pager to support your efforts on the Hospital at Home Users Group website. It's under the Technical Assistance tab and Policy Education. I think it's the first link there. And this really details what Hospital at Home is, the history of the waiver in brief, and a lot of the existing evidence that supports how Hospital at Home care reduces spending, which is a key priority of Congress right now, expands access in rural and other underserved communities, and really enhances the patient experience. So this is a great resource, and we hope that you'll use it in your conversations with lawmakers. Okay, I think that's it for me, and we are happy to take questions. I will start looking at the Q&A to see if we can answer these.
Meredith, I know we have Danielle on, and Mandy McGowan had a follow-up question that we wanted to make sure we teed up for Danielle. So Danielle, I don't know if you are able to talk, but Mandy's question was basically follow-up of the earlier question, which is to say, if there's a lapse in the waiver, the state allows hospital at home for non-Medicare and Medicaid fee-for-service patients. Does the lack of the waiver still mean that hospitals must provide 24/7 nursing to provide inpatient care? So how does that participation impact the non-Medicare and Medicaid population?
So for the non-Medicaid and non-Medicare patients, your Medicare Advantage, your commercial providers, you would still be able to provide that because those are the conditions of participation to participate in Medicare. And because they're not receiving Medicare payment for the hospital's not receiving Medicare payment for those patients, you would still be able to provide hospital at home care and waiving the 24/7 requirement, because that's only a requirement for Medicare and non-managed care Medicaid.
Okay. Meredith, I'm going to jump in with a question myself. What do you think? Do you think it could be possible to get a 5-year extension in September with the argument that this is budget neutral, so we don't have to have a fight about money? So just put a 5 up there and a YEAR, and let's be done with this.
Yeah, if only it were that easy, right? Lisa, I do think that there's an opportunity, and like I said earlier, it really comes down to some of that education. I think members of Congress would really benefit from hearing more about the really excellent care that patients are receiving in their homes and what that flexibility really allows the hospitals participating to do. And the goal of the Hospital at Home Users Group creating that evidence review document is really to answer some of those key questions that we hear from lawmakers, like, this is a new program, and how do we know that it's working well? Are we sure that we should do a longer term extension, or do we need to retain this option for a shorter term extension so that we can make changes? And so I think the goal of that evidence summary is really to answer that question and say, we have the evidence. We know that this is going well, and take all of that evidence and put it next to the CMS report. And there's a lot of information there to support a longer term extension. So I'm really hopeful that there's an opportunity, particularly because there's no price tag on this one, but would definitely encourage folks to engage their members of Congress.
Yeah, there was a question for you around any chance there would be a standalone vote on hospital at home or the Modernization Act. What do you think?
Yeah, so I think I said this earlier, but it bears repeating. The Congress absolutely has the authority to pass an extension of the waiver separate of government funding. It's just that Congress typically likes to do these things together. So the fewer votes they can have, that's generally what they prefer. So we have historically seen these types of extensions move with government funding. And so we would expect that to happen again. But they do have the opportunity to do a standalone, to pass it alongside other legislation if they wanted to do that. It just doesn't seem like the most likely outcome.
Gotcha. And I think the last question in the chat that I saw was around healthcare workforce. You mentioned a number of the priorities of the administration, Secretary Kennedy, and where does healthcare workforce come in their list of priorities?
Yeah, I think that's a great question. The administration talks about the healthcare workforce actually related to most of those priorities that I was talking about. I think they really see the key role that healthcare providers play in their communities as trusted individuals. And we don't have healthcare without the folks who deliver it. And I do think the administration understands that. And so we've seen a couple of initiatives to support the healthcare workforce. The one I would call out most readily, and that's probably the most timely, is in the One Big Beautiful Bill Act that I mentioned, Congress enacted the Rural Health Transformation Program, which provides $50 billion in funding to states who have to apply to the program. That $50 billion in funds will be distributed over 5 years to states with an approved application. And one of the sort of approved uses of those funds is to support the rural healthcare workforce. And so I think that's a good example of where we might see the administration infuse resources to supporting the workforce in the near future.
And actually, I know of at least one state that is attempting right now to use those funds to help rural hospitals start up hospital at home programs. So thank you so much, Meredith, for your time today, and certainly for Danielle and Ashby as well. And Gabby, I think you were going to close us out. I see it's 4:59. So
Yes, thank you all so much. That was really so informative. I learned so much. So thank you all. And as we close out, just a quick reminder about registration for the annual meeting. You can click that QR code to get registration. Please join us. It's going to be great, and hopefully we'll know about the waiver by then. And as a reminder, we also have the hospital at home quality minimum data set. We are looking for information on all patients enrolled in hospital at home programs nationwide dating back to November 2020. We currently have 46 sites actively collaborating with us, and participating health systems names are not going to be shared, and participation is completely free. You can find more information at that QR code. And you can see more of our webinars on our website. We have 34 so far, and we have more coming for you in the coming months. Stay tuned. So for more information, please head over to our website, highusersgroup.org. You can also find all of our technical assistance there. And our featured resource at the moment is an introduction to age-friendly care and hospital at home. And lastly, of course, we'd like to thank our partners at the Johnny Hartford Foundation and the American Academy of Home Care Medicine for all of their support. Have a great evening.